Hi, I'm Rebecca Kruse-Jarres. I'm with the Washington Center for Bleeding Disorders in Seattle, and it is my pleasure to talk about a passion of mine, which is acquired hemophilia A. And to give you this module 16, this is the first part, and we're going to review the current state of the art and future direction. So we're going to start with just saying, what is standard of care in acquired hemophilia right now? And then we'll follow that with part 2 and 3, case discussion, and future directions. So starting with part 1, a brief overview of the current knowledge on the topic. Firstly, I want to disclose that I am a paid consultant to Roche and Bio, and I'm receiving some research funding from them. And later on, I will be discussing emicizumab as an off-label option. So to review acquired hemophilia, it is an autoimmune disease. It's IgG-mediated disorder. And this disorder occurs mainly in an aging population, both male and female, as you can see here in this retrospective review. The older people get, probably immune systems being not as streamlined. But we also see this little blip right here in younger females around childbearing age, where it's associated with pregnancy, especially postpartum. So altogether, 50% of patients really do not have an underlying comorbidity, but the other 50% do. And that can be other autoimmune disorders that shouldn't surprise us, but it can be things like malignancy. We already talked about pregnancy, infection, certain medications. And this often happens in an elderly population that already is at increasing risk for thrombosis and now may have an additional comorbidity that's adding to this risk of thrombosis. So we have a bleeding disorder that's occurring in the setting of a potential clotting disorder to keep in mind, and that makes it difficult to treat these patients sometimes. Like I said, it can be drug associated, and there was a really great report that was published with drug-reported acquired hemophilia between 2004 and 21. The highest association was with alemtuzumab, clopidogrel, and omalizumab. We also recently, over the last few years, with COVID outbreaks and COVID vaccines, have an increasing number of case reports where there seems to be an association with maybe the COVID infection and certainly the COVID vaccine. So something to look out for. Unlike congenital hemophilia, acquired hemophilia has bleeding phenotype that presents in skin and soft tissue. Deep tissues, musculoskeletal, retroperitoneal, and these skin manifestations can be very severe, leading to the need of blood transfusions in the case of deep tissue bleeding, muscular bleeding, into compartment syndrome. So this can often be severe bleeding. And this bleeding tends to be spontaneous. And even though we have an old elderly patient maybe in front of us that's presenting with this widespread bruising, we easily accuse that patient of having fallen, and they have not. This can happen spontaneously, and we need to keep that in mind, but certainly can be trauma associated and during surgery. So it is very important, I already said, that these are severe bleeds. Easily see drop in hemoglobin, need blood transfusions. It can lead to a compartment syndrome. It's not something where we want to send this patient home and say it's going to be fine. These are people that need hemostatic management to stop the bleeding. And at the same time, we need to address what's causing all that, and that's the antibody, and see what we can do with immunosuppression to get rid of the antibody. So I'll talk about both of those. What's being attacked here is human factor VIII. We can replace that in the form of ddAVP, fresh frozen plasma, and factor VIII concentrates, but it doesn't make sense that these would work really well because they're presenting that same protein that's being attacked by the IgG. So much better options are bypassing agents in the form of activated prothrombin complex concentrate or recombinant factor VII activated, or porcine factor VIII that is not necessarily recognized by this IgG antibody against human factor VIII. So sometimes it evades that immune response. And we'll talk a little more about that. So if you have nothing else available to you, could one try ddAVP, fresh frozen plasma, or factor VIII concentrate? One could in a bind, but it's not likely to work very well. So we really want to focus on these bypassing and porcine replacement agents. And especially in the bypassing agents, this is an older publication, but a very important one. It's a registry that looked at that. And they showed that patients actually were quite responsive to both recombinant 7 and activated prothrombin complex concentrate. And you can see that control of first-line bleeding was over 90%. So certainly a good option. Both of them have to be given IV. Both of them do not have laboratory monitoring and therefore need clinical monitoring. So a close observation of the patient, and that often for both of these reasons requires hospitalization. The recombinant porcine factor has been approved by the FDA for on-demand treatment and control of bleeding episodes in adults with acquired hemophilia. And what we saw in this very small clinical trial, it was a prospective trial of 29 patients. It's a rare disease, that we achieved 100% efficacy at 24 hours. Now, we need to look at these patients and see whether there was any cross-reactivity. And if we look at these 29 patients, we see that at the start, we did have actually 10 patients that had cross-reactivity of the IgG to the porcine factor, and some of them quite high at 29 Bethesda units. But yet, with sometimes relatively large doses, but we were able to overcome that and achieve 100% hemostasis. Now, of the 19 patients that did not have cross-reactivity of this inhibitor to the porcine factor, 5 of them eventually during treatment did have cross-reactivity, and at that point quite high, to the point where this product was no longer achieving the hemostasis that we were hoping for. So it's a great product initially. It will very likely achieve good hemostasis, but we need to be mindful of the limitation with the cross-reactivity of the inhibitor. So the safety and efficacy of patients with inhibitors of more than 29 Bethesda units really has not been established. And because that reactivity can happen at any point, we're going to have to be mindful that we monitor patients with factor VIII activities. It's the one-stage assay that needs to be done to monitor these patients. And therefore, it's also given IV, and it also needs close monitoring, and therefore often necessitates hospitalization. So just summarizing here, these are the agents that would be recommended for initial hemostatic management in this patient population. It is also very important to note that none of them are approved for routine bleeding prophylaxis. They can be given for surgical hemostatic prophylaxis, but they're not approved to send this patient out on to prophylax him against any further bleeds. And with that, we have to ask ourselves, what is the risk of somebody, once the initial bleed has been addressed and the patient is stable, what is the chance that this patient is going to bleed again? And here's a very important study that was published by Holstein out of the Andreas Tito group that looked at this prospectively in the GTH-AH 01-10 study. They had 102 patients, and they looked at the risk of rebleeding, you see here in days. And they saw that of all patients here in the light blue, over 50% of patients had rebleeding, and just under 50% had treated rebleeding. Now, if somebody's in partial remission with a factor VIII activity of 50%, at least 50%, then this bleeding risk goes down very significantly. Let's take a look at what that means. Does factor level correlate to that? Does time correlate to that? And they looked at that too. And they saw that here are, in these different colors, you can see factor VIII activity less than 1%, 1 to 5, 5 to 20, 20 to 50, and over 50%. So again, here, partial remission in the dark green. But you can see if you're not in partial remission, that the bleeding risk is significantly higher. And that even with factor levels of maybe 30%. So something that we're not used to from congenital hemophilia, these inhibitors are behaving quite differently. What's interesting in all of them is that if you look at bleeding risk over time, it seemed like it was particularly high in the first 6 weeks, and then in all factor level groups was decreasing over time. So with that being said, the rebleeding risk is very high. So we cannot just ignore this inhibitor. It's not likely to go away by itself. So we need to address that, and we do that in form of immunosuppression. In international and various guidelines, here are just some of them. The most often used agents are corticosteroids, corticosteroids with cyclophosphamide, corticosteroids with rituximab. And here are various dosing. Now, that GTH-AH01 2010 study actually had an algorithm that they followed in their patients, and there are 102 patients. And I think it's a very good algorithm that if you don't know where to start, I think this is a good algorithm to follow. And where you start with prednisone, you see where the patient's going to go for the first 3 weeks. If they still have an inhibitor that doesn't seem to move very much, then you add cyclophosphamide, and after another 3 weeks, consider rituximab. Unless patients cannot really take prednisone or cyclophosphamide for any good reason. So using this regimen, they showed that 83% of patients achieved partial remission after 31 days. So again, that is a month of high bleeding risk, but eventually a lot of them achieve partial remission. But of them, 22% relapsed after that partial remission. They achieved complete remission in 61% after 79 days, but of those, almost a quarter relapsed. So people need to be monitored quite rigorously. And they saw throughout all this, they had a 33% mortality. And this is a mortality that we've seen in a lot of retrospective studies. So something that rings true, and something that is very considerable. 14% died due to complications from the immunosuppression and not necessarily bleeding. Another regimen that I want to discuss here that is coming from a single institution and is retrospective review of 32 patients, but they gave an interesting regimen of cyclophosphamide IV on days 1 and 22, dexamethasone 40 milligrams IV or PO on day 1, 8, 15, or 22, and then they gave a low dose rituximab on day 1, 8, 15, and 22. They had a decent follow-up of their patients, and they found an astoundingly much lower mortality rate. Now, can you compare these two studies? No, you can't. You have a multi-center prospective study, you have a retrospective single institution, but I think it should make us alert that this is a regimen to explore. They also had a remarkable complete remission rate. Again, I think this is something that needs to be looked at more, but it's an interesting regimen. Very importantly, I told you that steroids and cyclophosphamide and steroids and rituximab are in this initial mix. And this study group looked at to compare these two regimens. In red, you have the regimen that contains contains rituximab and steroids, and then in blue, you have the cyclophosphamide and steroids. And as you can see, there was really no difference in complete remission rate. So either one of them seems to be equally well. The first infection or death due to infection or treatment also was no different in the two regimens. So based on this study, it seems like it is equivalent. Interestingly, and really not in clinical trials, but starting to be in clinical trials, but there are several case reports, and that is to address the actual plasma cell and giving anti-CD38 antibodies. That can be bortezomib, that can be daratumumab. Both of them, I think, very interesting agents that we don't have a lot of data on, but they're certainly ripe for exploration, and I'm glad to see that there are clinical trials coming up. So I hope I was able to show you a little bit about what we're doing right now about acquired hemophilia. What do we do for hemostasis? What do we do for immunosuppression? And we have a little e-learning quiz. Get ready. All current approved hemostatic agents for acquired hemophilia A have good hemostatic potential, can be given IV or subcutaneously, should be monitored with laboratory assays, and can be given in the outpatient setting. So the answer here is they all have been shown to have good hemostatic potential. That is to control the acute bleeding. Again, it's not for long-term prophylaxis. We don't know what they do and how they should be given. They all have to be given IV. While the porcine recombinant factor can be and should be monitored with laboratory assays, both of the bypassing agents cannot. And I don't think that any of these agents are ripe for outpatient setting. They would be very difficult to administer. So with that, I thank you, and I'll see you in the next module.